Welcome to Health Literacy Out Loud. I'm Helen Osborne, President of Health Literacy Consulting, founder of Health Literacy Month, and author of the book Health Literacy from A to Z. I also produce and host this Health Literacy Out Loud podcast that focuses on many aspects of health communication, patient education, and health literacy. Today's guest is Dr. Matthew Davenport, who is professor of radiology and urology and also executive vice chair in the Department of Radiology at Michigan Medicine. Matt is also co-director of the Weiser Center for Prostate Cancer. He's the co-author on national policy statements and has published over 250 peer-reviewed manuscripts. Matt Davenport is frequently interviewed regarding important issues in radiology, including in the Wall Street Journal, the New York Times, NBC TV, and numerous national magazines. And now he's on Health Literacy Out Loud. Welcome, Matt.
Yeah, thank you for having me. I really appreciate it. I'm looking forward to our conversation today.
I am too. I found you when I was doing a search for a topic called incidental findings. Some of my friends have had odd results show up when they've had a blood test or they've had an imaging test, and like, where in the world did that come from? And I know the name for it is incidental findings, but I don't know a lot more about that, about what they are, and mostly how do we communicate them. Then I found your wonderful article, Incidental Findings in Low Value Care, that was in American Journal of Radiology, I believe. And I'm so glad you agreed to be a guest. You're the pro. Please tell us all, what are incidental findings?
Incidental findings are what you might find on a diagnostic test, like an imaging exam or a laboratory test, some test that's being done to make a diagnosis, but that are unrelated to why that test was done in the first place. So an example might be someone has terrible abdominal pain. They're worried they might have appendicitis. They go to the emergency department. They get a CT scan of their abdomen and pelvis, looking to find the cause of pain, looking to see if it might be appendicitis, and they find something in the left adrenal gland, which would be totally unrelated to why the person was in the emergency department. That's an example and also a definition of incidental findings. And they're actually quite common. Incidental findings on advanced imaging tests like CT or MRI, they're estimated to occur somewhere between 20 and 40% of the time. So a large minority of patients will have one.
So this person you described, it must be in pain, is in a medical setting, might have appendicitis that might mean all other sequelae in their life, including surgery, and all of a sudden something else shows up. What happens? I'm thinking of that poor patient there that now has at least two big problems to worry about. But what's it like from the patient perspective, and what's it like from your perspective as a physician and as a scientist?
On the patient's perspective, because of the definition of incidental findings being something that's unrelated to why they were getting the test in the first place, they usually come as a surprise. And the patient says, wait, what? There's something there? What does that mean? And that creates some amount of uncertainty. Is this finding important? Is it unimportant? Or is it somewhere in between where we're not sure if it's important or not? That uncertainty then says, well, what do I do next? What do I do with this finding? Is it important? Should I worry about it? Do I need to do more testing or not? On the medical side, we are trying to triage whether that finding is important for the patient or not. And deciding, is doing more testing and intervention to work that up or to investigate it going to create health value to the patient? Meaning, is it going to make them healthier? Are they going to live longer? Are they going to have a happier life by investigating this finding? That's the goal, because every physician's purpose is to try to make their patients happier, healthier, and live longer. All of us, that's our profession. That's what we're trying to do. So when we look at one of these findings, say, are we supposed to do something with it or not? There exists an array of guidelines that help govern what to do in these settings. incidental findings guidelines that say, if you see this in a patient of this age, take this action or do this activity.
Oh, okay. I didn't know there were guidelines. I had this image as you're describing it that everything has to happen very quickly and in the moment because you still have an acutely ill patient. And now you have this. So what's buzzing through the patient's mind is, oh my, and then what's going through the doctor's mind would be more reason like the triage, like the tree. Where do you go with this one? But it's happening quite quickly, isn't it?
Part of the triage is determining, is this incidental finding unexpectedly related to why someone is there, which is rare. That's not normally the case. In which case, it is tied together with the acute condition.
Okay.
It's something that is something the patient has had for a very long time, and they just didn't know about it. It was inside the patient, and they were not aware that it was there. If the latter is true, and that's usually the case, that's not typically an acute decision-making process on average. So on average, the acute condition is managed first, and the incidental finding is managed later. Often it's worked up as an outpatient after the person has been released from the hospital or the emergency department. It's complex because depending on where the incidental finding is, in what patient population, what the risks are, how risky the finding is, there's a whole branching, complicated tree of decision-making that happens from there. So it's not one size fits all.
That's what I was thinking about, wondering about, is that tree of decision-making and also the benefits and risks. And also my background, I worked in psychiatry for years as an occupational therapist. Plus, I'm just a regular old human being. And I'm thinking of the emotional aspect of this. You have the physical aspect of this, but the emotions of this. And that worry may not go away very easily, even though maybe a physician might be able to dismiss it a little bit. Can you talk more about the physical findings and the emotional aspect of this?
Yeah, that point you mentioned, I want to anchor to a little bit because there is a big difference between how a physician handles emotion with the incidental finding and how the patient does. And the reason why is because incidental findings are quite common. So the physician sees them. A radiologist like myself, for example, sees incidental findings every single day that we practice.
Oh, every day you see
Every day. So 2 to 4 patients out of 10 would have a finding like this that's unexpected, that's in your body, and we're trying to figure out what to do with it. So because a physician might see it regularly and on a recurrent basis, and we're kind of planning how we're going to manage it, there's a calmness that comes with the triage of that finding because we're so used to seeing it. For the patient, it's a different emotional reaction because they weren't expecting it. Remember, that's the definition of the finding. It was unexpected, unrelated to why they were there in the first place. And so that triggers some anxiety in many patients, not all, but in many patients triggers some anxiety. And they say, is this important to me or not? Now, sometimes they might rely on a doctor or a nurse practitioner or a physician assistant or someone explaining what the finding means, and that might calm them, but not enough. They want to do their own research, as they should. They'll go online, they'll look things up on a large language model, they'll ask their friends, they'll call their brother or sister who's in the healthcare profession or some decision making, right? And an intense series of research often takes place for people. They say, is this important or not? And then when a decision is made about how to manage that finding, and many times it's getting more testing. So let's say we found something in the adrenal gland. Many times it results in more things that are done, like laboratory testing to figure out if it's making a hormone or not, for example, or another consultation to see another doctor to weigh in on the importance of the test or not. So it generates more stuff, more engagement.
Right.
And the act of engaging with healthcare in that way may create some reassurance and also may prolong the degree of psychological uncertainty for that person. And in some of these cases, for incidental findings, the recommendation is for very, very, very long-term follow-up on the order of 2, 4, 5, 10 years of follow-up. And then it becomes kind of someone's annual experience is to go get this thing checked in on. So it's always lurking, in the back of your mind. If it wasn't important, I wouldn't be getting this follow-up test. It's not changing, and I'm still engaging with it. So it creates this unease. if that makes sense.
Oh, it makes sense. I'm living through this. I'm thinking of all those stories. For me, who carries these odd little things on a health history because they showed up somewhere. I'm also the one, because I do know something about healthcare, that my friends call, like, what is this? And why do I have to go through this? And I'm also thinking about this from a health literacy perspective. This is complicated. And we have come at this in very different ways. How in the world do we communicate to our patients and to ourselves and to the public about incidental findings?
Right. It's a challenging thing to do, and probably the conversation with each patient is tailored by their caregiver depending on what their needs are and what information they need to hear to make that decision. Physicians' general goal is to be transparent with what the benefits and risks are of what they're undertaking, but it's very complicated, as you say. It's hard to succinctly express the probability of risk or the probability of benefit because many times the doctor themselves don't actually know.
Oh, okay. Tell me more about that.
Yeah, this is an important part of the conversation, actually, is I mentioned before that we have incidental findings guidelines, and the purpose of them is to try and give some guidance as to what to do next when these findings are identified. Most of those guidelines are not super rigorous. They're not, and by that I mean they're not very evidence-based in many cases. There's some evidence behind them, but the guidelines don't show that following the guidelines results in healthier, happier, longer-lived patients by and large.
I'm just going to ask you to be a little more specific. Do you want to keep going with that person who has this adrenal finding? What do you mean by those guidelines not being specific? Give us some examples.
So the guidelines oftentimes are fairly prescriptive. For an adrenal nodule, for example, there's pretty well-described guidelines of what to do when an adrenal nodule is found incidentally. And it depends on what the imaging characteristics are, how old the patient is, and based on those, there's a decision made about whether to do more laboratory testing to see if that nodule is making hormones or an imaging follow-up test to make sure it's not changing or not. Those are rules that have been written into a guideline people will follow. However, those rules were not created out of a randomized controlled trial proving that they actually help or that they actually create health value to patients. They're based on assumptions or intuitions or a guess, an expert opinion, for example, on something, as opposed to rigorous science. And that's true for a lot of the incidental findings guidelines that we use. And when we consider those incidental findings guidelines, they tend to take an approach of, we're going to maximize the odds that if there's something bad, we're going to find it at some point. We're going to try to do that. If there's something there, we're going to really emphasize on the detection side of finding that rare bad event. Incidental findings guidelines, and these are big, broad, sweeping statements, so I'm trying to be careful, but they tend to discount the risks of the interventions that are involved in finding the diagnosis.
Meaning what? Discount the risks.
Odds of something being bad in that adrenal nodule was 1 in 100,000 or 1 in 10,000,
Right.
some uncommon event, let's just say, for sake of argument. And the act of trying to find that 1 in 10,000 or 1 in 100,000 needle in a haystack through all of the investigations, you incur harm from investigating. You incur harm both on the psychological side and also on the physical side from taking interventions to investigate and work up the finding that you've identified. So that harm can come from a cascade of additional testing that finds additional incidental findings. We call that a cascade of care, where you find one thing, you get another test, you find something else, you do another test, you find something else, and you end up this rabbit chase trying to find work
Right.
up. In addition to that, you might end up with direct harm if there's some intervention to investigate the finding, whether it's a biopsy or a surgery to resolve the uncertainty of what that thing is. And because we don't have randomized trials confirming that following these guidelines creates health value, we're actually uncertain. We in healthcare are many times uncertain about whether we're going to benefit or not, because a lot of them are based on expert opinion. And when something's an expert opinion, there's a value judgment that's placed on it.
Oh my goodness. I was just thinking of all that uncertainty, and we're living in a very uncertain time in there and all of that, but we can't let go of this. Thinking of the motivations for the doctor Can they let go of this finding? And what's the harm or risk of letting go? For the patient, can they let go of this and go, "Phew, does anyone, who else is involved in this process? And can anyone say no?"
Right. That's part of the issue here for sure. And I think doctors have to resist the urge to engage in what I would call paternalism or parentalism, where the doctor's making an independent judgment for the patient without the patient's input. I would consider that to be not in the best interest of patients as a general statement. If there's a finding that's unclear about its importance, then there has to be a conversation where the provider explains the risks and benefits to the patient. They have to kind of make a rational decision about what's the best next step to do. Sometimes that's an informal process where we just have a conversation, in a clinic room or something, or over the phone, an informal conversation. And sometimes it's actually a formal conversation. That's called informed consent, where we actually have it's like a contract or a document where we're explaining the risks and benefits formally, and someone signs a form. And that informed consent would be something like, for example, if you undergo surgery, or if you undergo a procedure, or if you are engaged in a research study, or doing something that's not standard of care, you're doing something that's strange or unusual, or you're guessing as to what something might be, that would require a formal informed consent. And in other cases, you don't require that if it's just regular healthcare and you're just trying to explain risks and benefits informally. So when we find a finding like this, we try to engage in a dialogue with the patient about what to do with it. And in general, we're informed by the guidelines. We might, and just to be clear, I'm a radiologist, so most of the time these conversations are happening between the patient and their primary physician. That conversation usually is something like the guidelines are explained and the uncertainties around the guidelines are explained to the best degree possible. And then a decision is made about what to do next. It's a fraught thing, especially in modern healthcare in the US, where you have, 10 minutes to have a conversation about everything that's going on. It's, shortcuts are no doubt taken in those conversations.
I'm sorry, I'm laughing
Yeah,
at this. This is overwhelming on this, and this is happening so much. For you, it's an everyday occurrence.
every day.
For me, oh my goodness, and now I'm putting on my health literacy hat. We have people we're communicating with, as you well know, as listeners know, who come from all levels of inquisitiveness and sense of self-advocacy and different languages and different cultures and literacy levels and emotions and disabilities. And yet we try to communicate clearly.
Yes.
Now we have this relatively common occurrence of incidental findings. From your perspective, what in the world can each of us do?
I think each of the parties has their own role to play in the conversation. I think on the radiology side or the pathology side, when a finding is identified on a diagnostic test, we have to do our best job to communicate to patients in a way that's understandable about what the potential risks are of that finding. So we have to do a better job, or as best job as we can, communicating the risks of that finding in a way that's understandable to a patient. On the provider side, the physician, for example, speaking to the patient with a finding, they have to do their best job to meet the patient where they are. Some patients are, let's say, highly sophisticated. Maybe they have a PhD. They've done all their research in advance. They're coming in to ask a higher level question. The nature of that discussion is going to really be fundamentally different than someone who maybe has a high school education, has done no research in advance, is very confused about the topic, and this is the first time they've engaged in healthcare. So those conversations are going to probably look and sound different, and it's probably appropriate that they do look and sound different.
Right.
Now,
Okay.
when those conversations happen, at the end of it, the fullness of what the finding is and what should be done next still needs to be communicated no matter what the person's background is. But the way that conversation proceeds is going to have nuance to it. And this is, a core feature of what healthcare providers do, is meet the patient where they are and give them the information they need in a way that's appropriate to them. And I think on the patient side, I think it's a combination of being great active listeners, preparing a little bit in advance for their clinic visit, and make sure they do their own research online and understand at least some of the basics about what they're getting themselves into, so they're prepared to have a thoughtful conversation about it. And I think another thing that's important is for the patient, this is really important actually, for the patient to express clearly their values to their caregiver. And the reason this is important is because we don't want the caregiver to be putting their values onto the patient. We want the patient's values to be front and center, and the caregivers just telling the different options and how they might fit into that value system. I'll give you an example. Let's say that someone is sick and they're towards the end of their life, and they've made a personal decision for themselves that they don't want to be maximalist anymore with their health. They don't want a bunch of interventions. They kind of want to take a step back, do something if something's really, really big, but otherwise, don't just leave me
Right.
alone. I say that's their personal perspective. That value statement is important to communicate right up front so that when the conversation happens, that caregiver can shape the information that's given and shape the recommendations based on what those values are. I think that's a really key piece of this. Another thing that a patient can do in addition to preparing in advance for that discussion and sharing their values, I think would be if they feel like they're getting a piece of information they don't trust or they're not sure what to do with it, it's totally okay to get a second opinion. An opinion can come from a traditional healthcare provider, or it can come from someone they trust in, the lay world, non-healthcare provider, someone they trust. They could say, hey, I just had this conversation with my doctor. This is what they said. Here's my values. Here's kind of what I'm thinking. Here's what I found online. Can we just talk about it and see what should we do about this? I think there's value in that, actually. I think, the healthcare provider can help, write an order for a test or, do a surgery or something. But they don't have to be the only source of information for the patient. The patient should be an active participant in their healthcare. And I think that we're seeing that more and more, actually, now in 2026, compared to 20 years ago or even 40 years ago, those kind of where the physician was sort of directing care and the sort of like just a captive audience member. We're moving away from that, thankfully. That's not really where we are today. The patient is making, they're a meaningful participant in it, and it's not just taking care of that adrenal nodule, it's taking care of the whole person, and all of it fits into that.
And that's what health literacy is all about, I think. To get to the core of what that's all about is that mutual understanding, so that what the provider has to say about this condition and what the patient understands, we both understand one another. So the provider can hear the patient's values and the patient can hear what the provider is saying that might be important. I just remember I was in a comparable situation dealing with some diagnosis, and then all of a sudden this whole team, it felt like they descended on me about, you really should have this other test and this other test and this other test. And I wanted none of it, but they made a compelling case. And I just remember kind of half laughing, half crying with them at the same time going, I feel like I'm the victim of medical excellence. So it's a hard situation to be in. But Matt, you have done a phenomenal job of explaining this from all the perspectives. I am delighted to have met you, read your article, and that you were a guest on Health Literacy Out Loud. We're all fortunate to have a voice of wisdom like yours putting all these complicated pieces together. Thank you.
I really appreciate the time, and it's been great to get to know you.
As we just heard from Dr. Matt Davenport, it's important to communicate all aspects of healthcare clearly and in ways people can understand and are respectful of our values. That includes these incidental findings that no one really expected to hear about that day. Communicating clearly your health message can be hard. For help, please take a look at my book, Health Literacy from A to Z. Feel free to explore my website, healthliteracy.com, or contact me directly at helen@healthliteracy.com. New Health Literacy Out Loud interviews come out the first of every month. You can get them all for free by subscribing at Health Literacy Out Loud or wherever you get your podcasts. Please help spread the word about Health Literacy Out Loud. Together, let's tell the whole world why health literacy matters. Until next time, I'm Helen Osborne.